Well, yeah, nice to meet you all. Thank you all very much for having me here today to talk. I'm excited to share some sort of new stuff that's happening in cystic fibrosis therapy. And some of this stuff is, stuff that's been going on for years, so it may not be entirely new, but we have some, what we wanted to do today was focus on things that are also directly related to research going on here at Maine Med. And as I hope many of you know, we're a therapeutic development network site here, so that we do a lot of research. We have a lot of active clinical trials. And so a lot of stuff I'm going to be talking about today is stuff that are active trials or things connected to active trials that are going to be happening around here. And I'm more than happy to ask questions as we go along. So please, if anything's not clear, if there's something I can explain better, please put up your hand, wave, and I will stop and try and go through it. So just so that you know, I have no relevant commercial interests here. As I said today, I'm going to start off with just a brief review of some of the basic science of CF, because actually in the last few years, we are finally starting to treat some of the underlying basic defects in CF, and so understanding exactly what the problem is makes it possible to understand what the goal of these treatments is. Genetics is becoming more and more important in CF therapy as we go forward, and so knowing exactly what the genetic defect is and how that affects the cell is really important. So we're going to review some of that. And then, as I said, we're going to talk about these new therapies, especially ones that are going on here at Maine Medical Center. To thank everyone on the CF teams. At events like this, sometimes the doctor gets up and says something like this, but this is such a huge team effort all the time, and so that we always want to acknowledge the fact that our team members make this all possible. So, starting off, as you all know, and something that everyone in CF knows and is very excited about, cystic fibrosis life expectancy continues to improve. This is the latest annual data report that was published. Our mean predicted survival age has risen to 36, and we certainly are getting better. We now are routinely seeing CF patients in their 50s and 60s on the adult side, which is really exciting, and is a huge change from even a few years ago. And obviously our goal is to continue that upward trend. As a consequence of this, as someone who's done training in pediatrics but now focused on adults, it's important to me is that you'll notice that the adult population just continues to rise and will continue to rise as we continue to extend life. And so that CF started off as a pediatric disease and is really becoming an adult disease. So, starting to dive into a little bit of the science, this is CFTR, the Cystic Fibrosis transmembrane regulator, and that is the protein that is at the heart of CF. And problems with this protein are what cause CF for everyone. And there are various genetic defects that go into this, but understanding, just sort of seeing the protein, so that you folks understand, this part right here is what we call the transmembrane domain, and this is where ions flow through this, and this turns out to be an ion channel protein. And all this stuff down here are the regulatory parts of the protein that control whether it's on or off. And we're going to see some movies of this in just a moment. CFTR is a chloride channel, which means that it allows chloride ions to move in and out of cells. Every cell in your body, as we all know, has a plasma membrane, and this is representative. This is a picture of a airway cell, and it has these little fringes on it. The CFTR, which is this yellow molecule right here, allows chloride, the Cl-, to move from the inside of the cell to the outside of the cell. And we'll talk about in a minute why we care about that. Who cares why chloride moves? It turns out to have some important effects. CFTR is a chloride channel, but it also regulates other channels. So you'll notice there's another channel right here, this orange one, and that is what's allowing sodium to come back into the cell. And the CFTR protein actually also regulates what that one is doing. So it's not just a chloride channel, it's actually got a lot of other functions. Now, as I mentioned, every patient with CF has a problem with this protein, but many patients with CF have different problems with the protein, and that really comes down to what the mutation is. And there are now more than 1,800 described mutations in CF, and we keep discovering new ones. And there are patients in this program who have a unique mutation that has never been seen before in the world, and because there are just such a variety of them. As scientists, we try and break down these into various types and the effect they have on how this protein gets to the cell surface and how it functions. And just so that these are some of the more common mutations here. F508del is actually 86.8% of the population has an F508del. And then these are the mutations that are in decreasing order of frequency the most common. But as I said, this list just goes on and on and on. And two that we'll be talking about today in specific are F508del because it's so common. And this second one, G551D, which is also one of the more common ones, but is so exciting because we have a new therapy aimed at it, which you folks have probably heard of, called Kalydeco or ivacaftor.
So what's class mean?
So the class depends on where the problem develops in the cell. So when you have a gene defect, there's a problem in DNA. The DNA is miscoded, and when that DNA gets processed by the cell to try and produce a protein, there can be various places at which there's a problem. So sometimes in class 1 defects, the problem is so severe that the cell is purely just unable to turn that DNA into any sort of protein. Nothing happens. There's no protein ever produced because the defect is so severe. In a class 2 problem, it's usually more of a folding or a trafficking problem, which is to say the cell tries to produce the protein, but the protein is misfolded. And F508del is mostly a class 2, which is to say the cell is trying and trying and trying to make CFTR and failing. And every time it tries to make a copy of the CFTR, that copy is defective and gets destroyed. And then it tries to make another one, and that one's defective and gets destroyed. And there's sort of this constant turnover. And then we have class 3, which is a regulation mutation, class 4, which is a transport mutation, and class 5. So we sort of divide up the problems in the cell on the basis of classes. And this will come into play because, if you have an F508del, what we really want to do is make sure that the protein folds correctly, and that would actually fix part of the problem. Of course.
So does the class correspond to the severity of the disease?
More or less. There is not one-to-one, but it is generally the case that a class 1 mutation, you're never going to make any protein, and so you're going to be very severe. In a class 3 or 4, you may have some function of the protein and you'll be less severe, but it is not one-to-one, and you can't map. We see patients with the exact same genotype, and some have much more severe disease than others, and so there are a lot of other factors that go into this. So it's not, but it is a general rule, sort of true. So let's actually take a look at a normal CFTR. So this is what's happening in anyone who doesn't have CF, all of those of us in this room, as we mentioned, because unfortunately we don't have any CF patients with us today. These movies were provided by the Cystic Fibrosis Foundation and presented first last year at the National CF Conference. So what we see here is what's called a ribosome, which is the factory of the cell, and it's making this protein. And this is what's going to become CFTR. And so you can see this little factory spitting out the protein. And as it continues spitting, it's folding. And you'll notice there's all this very complex movement going on here. After the protein has been folded and created, it actually clumps together in these little vesicles. This is happening inside the cell. And then it has to travel from the point where it's made inside the cell up to the plasma membrane on the surface of the cell, where it can actually do what it's supposed to do. So you can see these little vesicles coming up. They're spreading out. And now we're zooming in on a CFTR. And you can see these little green things moving through it are the chloride ions. So this is a normal CFTR with good chloride flux and is working appropriately. So why do we care about this chloride flux? Who cares? So chloride moves. It turns out that chloride is really, really important for maintaining this right here, which is called the airway surface fluid. So on the insides of your airways, and actually of pretty much of all mucous membranes, there is a layer of mucus, which is the stuff that we cough up sometimes. Underneath that layer, but above the cells, is this layer of fluid. And this layer of fluid allows these cilia right here, these little fringes that are supposed to be able to move, to have space to do so. Because if they get stuck, the mucus is thick. And so these little cilia can't beat if they're stuck in the mucus. But if there's water there, then there's space for them to beat and to move. So in a normal airway, there's this nice thin layer of liquid underneath the mucus. in CF, because of the fact that the cell is unable to excrete chloride, and it turns out that the way your body maintains that fluid and keeps that layer of fluid there is by controlling the amount of salt, and chloride is part of the salt molecule. NaCl is salt. In order to get chloride out there, you have to have a CFTR. If you don't have that, that water goes away. So here we have a non-functioning CFTR. The chloride can't get out of the cell, and you'll notice there's no water left. And all those poor fringes are being collapsed by that mucus. And what that really means is those fringes can't do their job of moving mucus. And it turns out that moving mucus out of the airway is really, really, really important. So this is actually a picture of a normal person's mucus. So this is what we do is we take little beads that are fluorescent and we scatter them over the top of the mucus, and then we point a camera at it, and you will notice that this mucus is moving. This is done in a cell culture, so it's sort of moving in a circular fashion. But in your airway all the time, this mucus is actually moving up from the alveoli towards the mouth. And the beating of those little cilia is what moves the mucus. If we take and look at a CF patient's mucus, so we take CF cells, these are cells that can't excrete the chloride, therefore can't create that water layer, so that those little cilia can't beat. Let's take a look at their mucus. This is a very boring movie. This mucus is not moving at all, and we will sit here for the next 30 seconds and continue to watch this mucus not move. This mucus is smunched on top of the cells. It can't move. It can't get out of there. And once that starts happening in the human airway, we start to develop a lot of problems. And that is really the basic pathophysiology of CF. So we have this gene mutation, and that causes a problem where you don't have the CFTR protein. You have abnormal sodium and chloride transport, so you don't get that water. The water goes away. And then you have this thickened mucus. And once you get the mucus that's just sort of sitting there and thick and can't move, it starts to get infected. And once it gets infected, that causes inflammation. And the infection and inflammation make the mucus even thicker. And that makes more infection, and we get this sort of nasty, vicious cycle that over time leads to destruction of the lung. And so this is a picture, this is a CT scan of a patient with moderately advanced cystic fibrosis, and you can just see big airways and lots of inflammation. Well, if you're good at CT scans, you can, but take my word for it, this is not normal. And we start treating CF. We can think about our treatments of CF as a part of this cycle. So there's a lot of things we do to try and break this cycle of mucus, infection, and inflammation. Antibiotics, we're killing the bacteria. Airway clearance, we're trying to get the thickened mucus out of the airway. Pulmozyme, or Dornase alpha, is a mucolytic. It loosens up the mucus and makes it thinner. So all of these types of therapies are based sort of down here. And this is where most of the advances we have made in the last 50 years in cystic fibrosis have come, down here, where the damage, the vicious cycle is already working, but we're trying to interrupt, we're trying to make it less severe. We do have a few therapies that we think actually affect the surface liquid, and hypertonic saline we think helps restore surface liquid, and so we're moving up a step towards the basic problem by restoring surface liquid. We have the ability for some patients to do lung transplant, and so if by the time your lungs get all destroyed, obviously we can come down here and give you new lungs, but as everyone in this room knows, that comes with its own set of issues, and we'd love to not have to get to this point. So that's why we're also excited about getting up here. Gene therapy is obviously something that everyone's excited about, but hasn't panned out in terms of actually, so far at least, in terms of actually fixing the gene itself. But what's becoming a reality is correctors, where the gene mutation remains, but we can somehow fix the actual CFTR inside the cell and make it function and interrupt this whole problem all the way up here. And I think that's what everyone in CF is very excited about. And so this is the CF therapeutic pipeline. You guys have probably seen this slide before. There's a new one published every year. It talks about the various things that are coming down the pipe in CF. And so that what we've been talking about right here is what we call CFTR modulation, where we're trying to fix the CFTR. And so we're going to be talking today about Kalydeco briefly, and then about a current study of a corrector called VX809 and Kalydeco. A couple of the other things that we're working on here at Maine Med include another study we're looking at pulmozyme, a study on a novel anti-inflammatory medication called KB001, and even in new anti-infective therapies. So we are continuing to push forward on all fronts here and at all points in this pathophysiology. But I won't deny everyone in the world is very excited about CFTR modulation. So let's talk about CFTR modulation. So I'm going to start with G551D because it is the one where we have proven that it works, and then we're going to move forward a little bit from there. So G551D, it's only 4.4% of the US population, but as it is one of the more common mutations. And the problem with G551D is that there is lots of CFTR at the cell surface, but it doesn't work. It is what we call a class 3 mutation. So you can see that sitting up here, there is a CFTR protein. It's just that none of the chloride's allowed to go through it. And so if we had some way to fix that problem, that might help. And it turns out we've come up with one. And this is ivacaftor, now being sold as Kalydeco. It is a small molecule. And I'll be honest, it's not entirely clear how it works. It was discovered in such a way that we know that it does work, but we're still actually working out the exact science of how it interacts with the CFTR protein. But it basically works like an on switch or turning up the volume. You have this CFTR protein that's not working, you add this molecule to it, and suddenly it starts doing something. It starts allowing that chloride to move. And so this is a picture of what we're talking about. This is another movie. And we see, once again, we're starting off right here. Here's the CFTR protein. And this CFTR protein is a G551 protein, and it doesn't work very well. So you'll notice all those polychloride ions are bouncing off. They can't get through. Suddenly, in comes this protein, and suddenly, this new drug, it hits the CFTR, it causes a change in the CFTR conformation, and suddenly it works. And all these chloride ions are allowed to move through the protein, and clinically, these patients get a lot better. So this was the big journal article that everybody in CF was all excited about back in 2011, where we looked at this drug in patients who had CF with G551D. It was 161 patients. And obviously, to be in this study, you have to have G551D, because if you don't have that mutation, the drug does not work quite so straightforwardly, at least. And this is the big exciting slide from that study, which is FEV1, which is the amount of air that people can blow out in the first second of exhalation, which we often use, and that's why we do a spirogram pretty much every time a patient comes to CF clinic. And you'll notice that as soon as patients started taking this drug, their FEV1 went way up, and it stayed up. And we saw a dramatic response in their airways, they got a lot better and they stayed a lot better. While the patients who were taking placebo just were on their normal sort of slightly downward trajectory over time in this study. So this drug seemed to work in people, which is extremely exciting. Yeah. This is an oral pill. This is a pill you take twice a day. And that's the other really exciting thing about it, is it's not an inhaler, it's not an infusion, it's a pill. And a lot of these small molecules, the goal is to have them be pills, such that you can swallow them, they enter through your gut, they get into your bloodstream, and they travel to every cell in your body and correct the problem. Another thing that we look at in cystic fibrosis when we're looking at outcomes is the change in sweat chloride. As you all know, that patients with CF have very salty sweat. It's another manifestation of the problem with the CFTR protein. And in those patients who were taking this drug, all of a sudden their sweat got a lot less salty. So it was working not just in their lungs, but on their skin. It was working in every cell of their body. Although obviously for CF, the major problem, one of the major problems ends up being the lung. But we would expect this would be helping the CFTR in the pancreas and everywhere in the body. And it was a dramatic drop. And that actually is an interesting thing, because we can actually graph the amount of sweat chloride that people produce, this is an interesting graph because we can take people. So here are people with who are normal, who don't have any CFTR problem, and they have about chloride of about 20 in their sweat. And you'll notice as we go across here, if there are patients, and some of them maybe in this room, who are CF heterozygotes, who carry one copy of a defective CF gene, but have a normal other copy, they have a higher sweat chloride than normal people. Not a big jump, but a little bit higher. And as we go across, there are people out there in the world who do not really have CF, but have a small defect in the CF receptor. And many of them, for men, are missing the vas deferens, which is the tube that connects the testicles to the urethra and allows sperm to move from the testicles to the urethra, which is one reason why patients with CF or men are usually infertile. So there are patients out there who don't have the vas deferens, but they don't have CF. Their CFTR doesn't work very well. It's enough so they have a little bit of it, but and then you'll notice their chloride is higher. And then we get patients with CF who are pancreas sufficient, and they have chlorides about 70. And then we have CF patients who are pancreas insufficient, and they have chlorides of about 100. And so we can actually graph sweat chloride levels and look at what does that mean for you. So if you have severe CF, you have a sweat chloride of above 80 usually. If you have mild CF, you have a sweat chloride between 60 and 80. And if you're below 60, you're essentially asymptomatic in many cases. And if we look at this drug, G551, and we take a patient with a G551D mutation who's got severe CF, and we give them this drug, and their sweat chloride drops by 50, in some sense, they may have dropped below the level at which they actually have clinical CF. They're still not down here at 20, but this is a dramatic change. And you can imagine that if this patient, if we could, get this level of fix early on, we could have patients who have much better quality of lives over time because they won't develop anywhere near as much CF disease. So that's the promise, and that's why we're so excited about this drug, because for these patients, this is a huge deal. So the question was, do these patients only take this drug now, or do they continue their regular therapies? At this point, they continue their regular therapies. Many of these patients, especially on the adult side, we only have a small number of patients with this particular mutation already have lung disease. They've had 20 or 30 years of lung disease, so they're not completely out of the woods. So at this point, our goal is for all these patients to continue all their other therapies, but they are all taking this, and I will say that anecdotally they're doing well with it. We haven't had any major problems with this drug so far.
Did they present this data to the FDA in getting this drug approved, and will they also present sweat chloride data for the next drug, for the Delta 508, to be approved?
Yes, so this was one of the outcomes of the trial, so certainly the FDA looked at it. I will say that sweat chloride is more of interest to us as scientists than to the FDA because no one dies from having salty sweat, and so that, from a clinical point of view, it's not as important whether your sweat chloride changes. As a scientist, when I'm trying to decide, have I helped this patient, have I fixed the defect here, looking at their sweat chloride is a relatively easy way to get an idea of whether I do so or not. So, now the one downside with Kalydeco is, as we mentioned, it works for 4.4% of patients. And this miracle drug at full retail price is costing, close to $300,000 a year. There are a lot of issues that arise from that. I think the biggest one for us as scientists is that we're not really, only 4.4% of our patients really benefit from this drug. And what we would like to do is extend these types of improvements to everybody. So, what if we could find more molecules that work for other mutations? And what if we could find something that helps with F508del, which, as we mentioned, is a very high percentage of our patients have at least one copy of F508del. So, just to dive briefly into F508del, 86.8% of the population has at least one copy. 47% are homozygotes, which means they have two copies of F508del. Not to get into the science, but the reason it's called F508del is it deletes the 508th residue in the protein. It is a processing mutation, so it happens down here in class 2. The cell is trying to make the protein misfolds, and the protein never gets to the cell surface and can't function because it never gets there, it never gets to where it needs to be. A secondary problem is that once it gets there, it doesn't work very well. So there is a small amount of protein that does get to the cell surface, but when it gets there, it doesn't allow chloride through very well. So let's take a quick look at what's going on for these patients. Here we can see a ribosome. It's folding this F508del. In comes some chaperone proteins which are helping it fold. Unfortunately, in just a moment, things are going to go horribly wrong. We'll start to see things turning red. Here we go. We're having some misfolding problems. Suddenly the cell realizes that this protein is defective, and in comes the cell's garbage collector, which is called ubiquinin, and is going to suck this thing in and destroy it. Okay? And that is what is happening over and over and over again inside the cells of patients with F508del. They try and make the protein misfolds, the garbage collector comes along and sucks it up and destroys it, and then the cell tries again, and it tries again, and it tries again. So, the new drug, VX-809, which is called ivacaftor, has been developed. Once again, we don't 100% know how it works. It helps with the folding. So we have a new drug that comes in, and we'll see in a movie in just a second, allows this protein to fold more effectively, and increases the amount of F508del CFTR that makes it to the cell surface. Now, this sounds great. Everyone was very excited about it. We did some initial trials, and when you just give them this drug, these patients did not have an improvement in FEV1 or other symptoms of CF. And that was a big disappointment. But we think we know part of the problem with that. So let's take another look at this movie here real quick. As I said, part of the problem is that F508del misfolds. So here again we see a misfolded F508del. This one, however, got missed and didn't get broken down. So it's being allowed, a small amount of F508del is making it out of, you can see some of those are disappearing, but every once in a while, even the F508del CFTR makes it to the cell surface. Unfortunately, if we're going to zoom in just a second and see this F508del, it's still not working when it gets there. So you'll see those little chloride ions are bouncing, and not able to get through. So even if we were to increase the amount of F508del CFTR that makes it to the cell surface, the stuff that gets there doesn't work very well. So that may be the explanation for why that drug did not work. Gee, if only we had a drug that makes CFTR work at the cell surface. But wait, we were just talking about that. Kalydeco activates CFTR at the cell surface. So what we're talking about is combining those two drugs, using one drug that will help the protein fold inside the cell, letting that protein get to the cell surface, and then giving Kalydeco or ivacaftor to allow that protein to work once it's at the surface of the cell. So here is what that would look like. We have this, once again, we're creating, here comes a ivacaftor or VX-809. Suddenly that's a much more healthy looking protein. It's folding much more correctly. And so we're seeing suddenly more healthy looking F508del being produced inside the cell. Some of that's going to pinch off and come up to the surface. And you will notice once it gets to the surface, it's going to start spreading out. And we're going to zoom in just a second. Here it is. It's still not working very well, but in comes another molecule, boom, open it goes, and suddenly we get really a significant amount of chloride flux. So that is the goal here, and this is the idea of combination therapy for F508del. And so we've done a phase, so far, where are we at with that? We've done a phase 2 study, which is a safety study, essentially. 109 patients. They all had F508del, either a single copy or a homozygote. They were 18 years or older. And it did seem to work. When we gave these two drugs together, they started actually in this trial, they started off just giving a VX-809, and that once again didn't seem to help. But once you had the VX-809 on board and you added ivacaftor, we saw a 8.6% improvement in FEV1 in the second part of the study. And some patients had a very dramatic improvement of greater than 5% or even greater than 10% in their FEV1. Now, that does imply that there were some patients who didn't get a huge amount of benefit from this drug combination, too.
Was there a difference between those who had a single copy or double copy?
So in this study, there was not a huge difference that we could tell. I'm sorry, the question was there a big difference between having a single copy and a double copy? And in this study, it wasn't really powered to look at that, so I can't answer that question well. So Maine Med is a site for the phase 3 trial of this combination. It hasn't yet been fully approved here, but it is going to be a multi-center randomized placebo-controlled trial, probably 300 to 500 patients. It's going to be ages 12 and above. We're going to be looking, almost definitely at FEV1 exacerbation rates, probably sweat chloride as well, and we are going to be hoping to start enrolling patients this summer for this trial. And we're obviously very excited about that. So I've got a couple minutes left. I wanted to run through a couple of the other studies that we're working on here at Maine Med, so that you guys know what we're doing. Obviously, our big goal with these potentiators and correctors is to extend this to all mutations. And the hope is over time we can continue to find drugs that affect all the various mutations that are out there and help correct them. There's a bunch of other drugs that are in trials. VX661 is a folding corrector. VX983 is a folding corrector. There's another company that's working on a drug called N30 that's a folding corrector. So there's a lot of activity out there on these corrector potentiator molecules, although many of the other ones are still very early in development and we don't have a lot of data on them yet outside of the outside of the cell culture. So other things that we're working on that are happening here at Maine Med. As we mentioned, modifying infection and inflammation are important. They will continue to be important. Even if all of these drugs work well, we will continue to need to worry about infections and inflammation. As we mentioned before, they don't change the underlying defect, but they decrease the damage to the lungs and the airways. Our goal is to decrease the loss of lung function and extend life. And honestly, they've been a mainstay of our therapy so far. The reason that we have increased life expectancy in CF so dramatically has really been with antibiotics, airway clearance, all the things that really are working down here. So we shouldn't dismiss this stuff as not important. It's very, very important. It's just not as sexy as these new drugs. The drug, one of the bugs that we care about a lot in CF and that all you have probably heard about is something called Pseudomonas aeruginosa. It is a common bacteria that lives in soil, water, everywhere essentially. Unfortunately, it really easily develops resistance to multiple antibiotics, and also unfortunately it tends to like to infect and colonize and infect the airways in CF, and such that 70% of adult CF patients are chronically colonized and or infected with Pseudomonas. And we know that once you develop that infection and colonization, you have a decrease in their lung function more rapidly over time. And this is just a little picture of Pseudomonas growing in culture. So it turns out that a lot of research is being done on Pseudomonas, and that Pseudomonas actually uses something called a type 3 secretion system to attack cells in the body. The type 3 secretion system is essentially like a little hypodermic needle. So this is a bacterium right here. It has this little hypodermic needle on its surface, and when it's damaging the airways and attacking the cells in the lung, it uses this little syringe to pierce the membrane of the cell and inject toxins that destroy the cell. And this is one of its major ways of damaging human cells. And so now that we have discovered this, there's been some interest in could we disable this type 3 secretion system. So patients with CF they would still have CF, they would still get infected with Pseudomonas, but what if we could give them a drug that would actually make the Pseudomonas not cause damage inside the lung? Then it wouldn't matter so much that they had this Pseudomonas in there, because it wouldn't be causing as much damage to the lung. And that's the idea here. KB001 is an engineered antibody, and it directly attaches to and disables this type 3 secretion system on the surface of Pseudomonas. And it's already been trialed in phase 1 and 2 trials and found to be safe and well tolerated. This is an IV medication. This is an injection that you have to get. And unfortunately, antibodies don't travel through the gut very well, so we can't give it as a pill. But in the early studies, there has been definite evidence of decreased inflammatory markers and trends, although not proven, trends toward decrease in pseudomonal disease. So it's sort of an exciting new therapy, and it's interesting because it's completely not an antibiotic. It's not killing the bugs, it's just sort of making them be harmless.
Might that be something, if it works, that people would take perpetually if they've been infected, just like kind of,
So yeah, once again, is that a problem with this? Yes. I mean, this doesn't get rid of, this isn't you to get rid of the Pseudomonas. It just means that you have to keep dosing this medication over and over again to keep disabling the type 3 secretion system. So yes, is it going to be something that would be continual? It would be. But we already use a lot of drugs, obviously, that patients are on forever. There's a phase 2 randomized double-blind placebo-controlled study of KB001 in patients with CF who have Pseudomonas. This drug is being developed by Calabios. We're a study site here. We're looking at safety, tolerability, and effect on pulmonary exacerbations. Essentially, it's going to end up being an infusion of this antibody every 2 to 4 weeks for a total of 20 weeks, looking at how things go. And as I said, it's an interesting new idea. It seems to work well so far in the early trials, and so it's another new and interesting idea that's floating around out there.
This is the first phase 2 study we've ever done.
Okay.
Yeah.
Dr. Carnes was saying this is the first phase 2 study that we've done at Maine Med. For those not totally familiar with the terminology, phase 1 is really safety or tolerability, and phase 1 is sort of trying to find a dose that works. Phase 2 is safety. Is this safe? And then phase 3 is really effectiveness. So this study is not trying to prove that this drug works. Right now, it's trying to prove that it doesn't hurt people. But we always look at evidence of benefit. So we'll be looking at safety, at the effect on pulmonary exacerbations. But just because it doesn't show in this study that exacerbations to go down doesn't mean it doesn't work, because this study is not designed to look for exacerbations. It's really designed to look for safety and tolerability. Another thing that's happening around here at Maine Med is more look at inhaled tobramycin, which we all know as Toby, and inhaled aztreonam lysine, which we all know as Caistin. As you all know, and we just talked about, Pseudomonas tends to get resistant, and we really worry about that because the more resistant it is, the harder it is to treat. And we have CF patients out there who have essentially pan-resistant Pseudomonas. The Pseudomonas have become resistant to all the antibiotics we commonly use, and that tends to make it harder to treat exacerbations. So another question that has come up, a lot of people are using these drugs in an alternating fashion, where you do a month of Toby and then a month of Caistin, a month of Toby, a month of Caistin. And the question is, does that really help? And does it decrease exacerbations and decrease resistance? So this is a phase 3 double-blind randomized controlled study of AZLI in a continuous alternating therapy regimen. So basically what they're comparing is Toby and Caistin versus Toby alone. So one group gets Toby plus placebo every other month. The other group gets Toby plus Caistin, and they switch off between them. And the question is, does actually adding Caistin make a difference to exacerbations, or are we just giving people Caistin and increasing the amount of money they spend, and taking a drug 3 times a day, which is a big pain, and not changing how they're doing overall. And so this is one of those ones where everyone thinks that Caistin should be helping, but we'd like to prove that Caistin is actually doing what we think it's doing when we give it to patients.
Are you part of many other sites that are part of the same?
Yes, so this is all of these are multi-center sites where we'll enroll a few patients in places all across the country. We'll be enrolling different patients. The last thing I wanted to talk about briefly was just new delivery systems. As we all know, all of patients with CF spend a lot of time treating themselves, and we're always looking for new and exciting ways to decrease the amount of time it takes to treat your CF. We're starting a study right now on looking at Pulmozyme via this new eFlow nebulizer, and trying to prove prove how that works. As we mentioned before, Pulmozyme really breaks up DNA strands and makes it in mucus and makes it thinner. If you use the standard PARI-LC+, it takes 10 or 15 minutes to give it. If you use an eFlow nebulizer, you can get it in 3 to 5 minutes. We would just like to make 100% sure that giving it via this new nebulizer, it works exactly the same as through the old nebulizer. Everyone thinks it does, but once again, we wouldn't want to give people a quicker nebulizer that doesn't work as well, because that really wouldn't be an overall benefit for them. So we need to make sure. So this is a phase 4, what we call a post-marketing trial, where patients who are already taking Pulmozyme would be randomized to either use the old one or the new one, and then they'll cross over and try the new one. And we're going to be looking to see if what type of nebulizer you use makes a difference to whether the Pulmozyme is working or not. So that's pretty much what I have for you today. there's a lot of stuff happening out there. This is just a taste. And as I said, we're focused on things that we're involved in here in Maine Med. So there, you know, I'm sure you all know, if you go to clinicaltrials.gov and put in cystic fibrosis, you will find pages and pages and pages of studies. But all of these studies are on there if you're interested in finding out more. There's also pages at the CF Foundation website that talk about these various studies. We're excited about the correctors, the potentiators. There's new anti-inflammatory and anti-pseudomonal therapies. We're working on nebulizers, and as a member of the Therapeutic Development Network, we're going to continue to be involved in new stuff coming down the pike. So, thank you all.